What about the microphone? Yes, ma'am. Ooh, and we're live. Why, yes, there is. Yeah, look at that. Good afternoon. I hope you all had a nice, nutritious lunch in both in terms of the food pyramid as well as intellectual fulfillment. We're back with the second half of our programming, talking about public service. As we shared this morning, the social and behavioral sciences influences health, not just in the academy, not just in multiple federal agencies, but in people's everyday lives. And we also talk offhandedly in the American conversation about the public and private sector as if they were two distinct spheres. And there are many, many subsets within them. The three women I'm lucky to be joined with now represent multiple aspects of the public sector sphere. And the first one you may not have heard of, Uma told me that she was surprised that I asked her, and I responded and said, I'm a proud citizen of Montgomery County, Maryland, and over 12 years. And in the time that I've lived here, I have seen the county change tremendously from one that was rather homogeneous in terms of its populace as well as its income to one that more greatly resembles the United Nations and for better or worse, also runs the gamut in terms of income, from the very wealthy to the very poor. And the director of the Montgomery County Health and Human Services Department has not only kept up, but led change in terms of that kind of programming, so much so that some of the programs that they've developed have become best practices both across this country and around the world. And so to tell you, Andrea, if you wouldn't mind handing unless you'd prefer to get up there, Uma, Uma Ahluwalia, take it away.
All right, thank you. Well, good afternoon, everyone. So I tried to do something a little bit different today. I saw the other day someone do an infographic of their resume, and I was blown away. I've never seen one of those. It was very exciting. And so I said, well, I've got to try it. And so I struggled a little bit, but I got something together, so I only have the one slide to talk from, but it's kind of interesting. But before I put that up, I want to tell you a little bit about our county. We have over 1 million residents since the 2010 census. So in 2014, according to the American Community Survey, we have about 1,100,000 residents, close to. 33% of our population is now foreign-born. Over 54% of our population is ethnic minority. Very different from what you would think of in terms of Montgomery County. We have a school system of about 156,000 students, and of those, 55,000 are free and reduced price meals. 85% of that are free meals, not reduced price meals. So it tells a story of poverty that you wouldn't normally think about. We've had the highest growth rate of the food stamp caseload or the SNAP caseload in the entire Washington metro region. 166 languages spoken in the county. So in terms of service delivery, it's quite challenging. We're an integrated health and human services department, which means everything you could think of, right? From HRSA to CMS, ACF, SAMHSA, what am I missing? ONC, everything sits over here. We have to pay attention to all of it through our state agencies. I was telling Bill earlier, I said, the feds don't really know Montgomery County because we're a local government, right? Most of your contact as the feds tend to be with state governments. Those are your clients. So it's kind of interesting. We have to insert ourselves into a lot of spaces, which we do quite a bit. So here's a little bit about me. So you can see it up there. I kind of ended up in public sector work quite by default. My father's a bureaucrat back in India, or he was. And So I guess it's a little bit in the blood, but that wasn't what I was going to do. I had my graduate degree in social work from India, and then I got married and came over here and got my degree validated through the Council on Social Work Education and said, I want to start working. And so my first job, making $17,000 here, working in a classroom with developmentally disabled adults, was sort of a very important moment, right? And then I had to get my work permit back then, so it was a lot easier than it is today to do that. Did a little bit of that, did that for about a year, then went and worked with dually diagnosed adults who are mentally ill and substance abusing. Fascinating experience. You have the most interesting conversations with people who are behaviorally challenged. It's really fun. And then ended up working in a nursing home, and then from there I did my master's in health administration and decided I didn't want to leave social work field. Went back, worked with seniors, and one day I was really frustrated. This particular organization had a very large board. They wanted to increase their revenue, but every time we'd have conversations, they would step back and say, no, but we're really about charitable contributions and free care, right? And it was really a struggle, and I think just out of curiosity, I put in my application for a job in Prince George's County at the Department of Social Services, and I forgot all about it. And about 3 months later, I get a call for an interview. And I go in there and not really expecting anything. I was supervising 15, 16 people. This was a child welfare department of 300 folks, and I didn't expect to get in. Once I interviewed, I really wanted the job. And so I go back in for the second interview, and then I'm pestering them. When are you going to make a decision? When are you going to make a decision? And that's how I started my public sector career. I worked there for 5, 6 years and definitely wanted to be in administration. And I realized as an immigrant, I didn't know how the executive branch and the legislative branch work together. And if I'm going to run government, anything in government, I need to know that really well. And so I made a leap of faith. At that time, Governor Glendenning was the governor in Maryland, and I went to work in the State House as the special assistant to the chief of staff. And my portfolio was health and a little bit of human resources and a whole host of other things. It was the governor's second term. He wasn't running again. And so I got to run a lot of things in the State House because people were leaving. You know how it happens towards the tail end of an administration. It was the most fantastic experience. One moment I was fixing coffee for the governor and figuring out it was the right wheat color. Next minute you're telling secretaries what to do, right? Kind of bizarre. So I did that, learned a bit, and then in Maryland we had the strangest thing, right? The Republican governor won, and at noon on Inauguration Day I was unemployed. Wasn't expecting it. I kept saying, but why would you do that? I'm good at what I do. Why would you get rid of me? I have since lost 4 jobs for political reasons, so I guess I'm a sucker for punishment. Done it over and over and over again. And then after that stint, I came to DC to the Child Welfare Agency there briefly, and then went to Washington State to be the Assistant Secretary for Child Welfare in the state of Washington. Again, child fatality happened over there, budget got bad, and the election happened, and I lost my job. And I had a young family. We'd gone over to Olympia, and there's nothing else to do in Olympia but state government. So if you lose your job, that's it. And so I called. There was a court monitor. I don't know how many of you know anything about child welfare, but DC's child welfare was under consent order. It still is. We haven't exited here in DC. And so I called the court monitor who just settled a consent lawsuit, a class action lawsuit in New Jersey. And I said, Judy, if you have a job, I can't find anything over here. And so she said, well, DC's looking for a deputy. Why don't you come back here? And that's how I came back to the East Coast. And 6 months later, my boss goes on to become deputy mayor, and I was running the child welfare agency in the city under Mayor Williams. It was just the most bizarre year. One moment I'm in the depths of despair, next moment I'm running a child welfare agency. And then Mayor Fenty came, and there's a residency requirement in the city, and I don't live in DC. So there I was having to look for another job. And Mr. Leggett had just won the elections in Montgomery County as county executive, and so I got the job. Now it's been 10 years. I've been running the Department of Health and Human Services in Montgomery County, Maryland. The fun thing about this position is that it's an integrated health and human services department. And one of the most profound realizations for me, and I can't tell you how important this is, we serve about 120,000 residents each year, and more than a third of those folks need more than 2 services from the department. And I don't mean TANF and SNAP. I mean things like mental health or maternal and child health or homelessness or domestic violence or income security, all kinds of things. And underlying all of it in some way, shape, or form is poverty. And so it's very hard to be poor in a wealthy community. And it's up to us to figure out how we're going to serve these clients where they don't have to walk around with the Rolodex of business cards for nurses and social workers and therapists. It's up to us to figure out how to reuse their information so they don't have to go through the trauma of telling that story over and over and over again. My husband beat me, or I'm going to lose my home, or my child has a disability. It's really up to us to figure that out. And so for the past 10 plus years, we've really focused our effort on integration and interoperability of health with human services. Talking about social determinants, what's the implication of that? What does it mean to do health in all policies? What does it mean if you have housing issues plus domestic violence, plus you need a job, right? Most families will tell you, we want to take care of our own issues, our own children. We don't need you to help us. So if you think about the safety net as a trampoline, and that's what we are as a department, we're a trampoline, not a waterbed. Nobody wants to come and hang out with us. They want to bounce off of it, go off into the universe, and then come back if they need us. But all the time, they're bouncing. They're up there doing great things, and that's what we want. And so that's been the work. It's intense. We're doing, as Bill said, lots of amazing work that's gathering attention. But most importantly, it's trying to come up with a framework for integration and interoperability around the practice. The policy, as you can imagine, HIPAA, 42 CFR, extremely challenging. Not HIPAA so much, but everything else. WAWA just happened, if you know violence against women, huge security provisions there. Substance abuse and 42 CFR, huge security provisions there. And a lot of our clients are dually diagnosed, doing methadone treatment, drug court. We have all kinds of things. And so how do you make sure that you're able to share information meaningfully? Figuring out child welfare, that's another interesting practice area that needs to be protected, domestic violence. So figuring out the confidentiality privacy environment, and if we could get some sanity around that at the national level, because here we're told, right, you go to any conference, they're telling you on any place else, share information so you can collaborate, you can figure out, and over there, ACF and Office of Civil Rights has said they're going to come and do audits on local governments to see how their HIPAA provisions and compliance is looking. And so how do you reconcile the two? How do you know that you're okay? How do you create a single message around confidentiality, privacy? It's not that privacy is not important, but it's also important to figure out some rational way in which to share data and information to build. And so the one thing very exciting since the Affordable Care Act, and then I'll stop, is the piece around not just billing and third party, because that's been scary, but what was I going to say? I forgot my thought.
You were tagging on to how Affordable Care Act
ACA,
is,
right?
Yeah.
So, yeah. I don't know. It was good. Whatever thought it was. It will come to me, but it was really good. Sorry about that. Does it? Oh, yeah. Well, there you go.
It's okay.
So it's a good world where I know, the hospitals, this was the point I was going to make. Maryland is a Medicare waiver state. And because we're a Medicare waiver state, there's been payment reform as well as service delivery reform going on in the healthcare system. And as a result of that, the hospital community benefits really becoming aligned with community-based services, which has been a fantastic opportunity for us. In Health and Human Services, we're doing a shared community health needs assessment. We're identifying priorities together, and we're making investments together in ways that will hopefully improve population health. And so very, very exciting times. Every day there's something new, and my staff are usually ready to tie me up somewhere and lock me up. But lots of good things to do together. So thank you.
Uma mentioned the Affordable Care Act, and just to my left is a woman who is helping make that happen, Ms. JaWanna Henry from the Office of the National Coordinator. JaWanna?
All right, thank you, Bill. I'm actually going to stand here at the computer. Oh, all right. So as Bill mentioned, my name is JaWanna Henry. I'm at the Office of the National Coordinator. What people would consider me to be an early career professional, and so I'm here to speak from that stance. A lot of people are always interested into how I got to where I am. I like to let people know that I am a native of South Carolina. I come from a small little town, and I was just telling someone where I'm from, we don't even think about careers in research or any research evaluation or any population health or anything like that. Most of the time you come from a small town, you are thinking about being a teacher or becoming a doctor. So I started off thinking that I would get into a career into the medical field, but ended up going to college, getting a graduate degree in exercise science because that's what I found myself interested in since a small child. And with that, I actually ended up at NIH, starting my career off actually in the fitness center, thinking that I would get into the research field from there, focusing on exercise science. But while I was there, I found myself being a little more interested in actually population science. I was thinking it would be exercise science, going to a field into physical therapy, and maybe doing research there. But in graduating with my bachelor's, I actually ended up doing AmeriCorps after I graduated. And many of you have maybe heard of Peace Corps or AmeriCorps as well, but the specific program that I did allowed me to travel for 10 months to different states in the United States, doing projects 2 months at a time. So at one point in time, I could be doing a construction project somewhere in Mississippi, helping rebuild homes from Katrina, or I could be somewhere in Florida, helping manage elderly services, so health services, transportation services for the elderly, or I could be found on an Indian reservation helping with programming for the Boys and Girls Club. And it was kind of that experience that got me into the whole population health. And so while I was at NIH doing fitness and personal training, I realized I wanted to do public health, and that kind of brought about my trajectory to getting my master's in public health. I started by getting a graduate degree in epidemiology because for some odd reason I was really interested in data and numbers. I liked crunching the numbers and being the first person to see what was going on in a population. And so to kind of get me started in that public health field, I decided to start with the basic science of public health, which is epidemiology. And then got my master's from the University of Maryland in Baltimore. And as I keep saying, I got my degree in population health. I'll probably bounce back and forth and just trying to tell my whole story. So as you see within my formal training with my Master's of Public Health, I was able to get training in research and evaluation. I focused on population health and then epidemiology. While I was getting my degree in public health, my evaluation course was actually one of my most favorite courses, and I just knew from that day forward that I wanted to do evaluation research. And so my position is at the Office of the National Coordinator, but I work in the Office of Research and Evaluation. As far as looking into my future, because I am a government worker, I hope that one day, like I said, because I'm an early career researcher, that I'll eventually become a research or evaluation lead of a project, eventually become a director of one of those offices for Health and Human Services. And if not that, at least become a director of some community-based programs within any state at this point. But also looking, because I look way into the future, but also being the CEO of a nonprofit of my own. I'm not quite sure what that will look like, but because I have the interest in exercise science and population health, I'm pretty sure at some point in my lifetime, I'll figure out how to merge the two. So on the job, achieved expertise. As many of you know, when you get a master's of public health, and it's kind of like a general master's in public health, there's some basic core classes that you have to take. So the epidemiology, social and behavioral sciences, policy, and environmental science, which surprised me when I took that one as well. So some of those skills are useful whenever you start your career, but as you kind of start your career and get into that first job or two, you continue to learn past those skills, so and gain more knowledge of those skills. So when I say on-the-job expertise, these are some things that I studied in school, but I just became more experienced in them with my job. So you can see here, I do a lot of data entry and analysis and management. For my job as a public health analyst, I do all of my data entry and analysis using SAS and then starting to get into using our statistical software. As I mentioned before, I do a lot of program evaluation. Within the Office of the National Coordinator, we have many offices. We give grants for different projects related to electronic health records. So we have grants working on the workforce. We have grants that we give to the community to learn how to better use electronic health records. And in our office, we get data from many sources. So we work with CMS, we work with HRSA to get data pretty much to analyze the uptake and the use of those EHRs and report that data back out to the nation to see how we're doing. As far as the evaluation piece, we do a lot with evaluating those programs, so those workforce programs and those community programs that we get grants for. And in that process, we also work on the survey development, so developing measures to evaluate the roadmap that we just came out with for ONC, but those programs as well. The thing that I wasn't too fond of or too knowledgeable about was the health IT policy. That was one thing that I had to learn coming into ONC because I knew a lot about the research, the data analysis, and the evaluation, but some of that background policy information, that was something that I had to learn on the job, as well as the things of health IT standards. So when you're talking about something about the roadmap or even health IT policy, that was far from what I learned while I was in school. So as an early career professional, one of the things that I had to learn how to do was pretty much just come in the job with my basic skills of research, but be able to pick up those topics very fast, because we can come into work and get asked to do analysis on a topic that we may, well, me, because I'm early career. There are people who are more advanced than me or subject matter experts, but you have to be able to learn about that topic quickly so that you can be able to develop good reports. Again, more on-the-job expertise is the community organization, so knowing how to organize people in the community. We work a lot with grantees. Again, because I work with evaluation, I get to speak with or work with the groups that work with the grantees for our community projects. And one of the last things that if you are a government employee, you know about this contract management, because we don't do all of our work, we do contract it out to people. So really being able to manage contracts, large contracts, as a matter of fact, not just $2,000 contracts, but $1 million contracts. And so that was one of the things that I really had to learn on the job. I hope I'm not forgetting anything, but I guess if I am, Bill will have some questions for me. Some of my major career moments, again, just coming from an exercise science background and getting into public health, one of the major things in my career was actually traveling to Honduras. I had the opportunity to travel to Honduras 2 times while I was completing my Master of Public Health degree. And I traveled as a global medical brigade member. And with that, I actually went over to Honduras and helped build medical clinics. We set up medical clinics in schools for about a week, and that was giving treatment. So I went with a lot of pharmacists, pre-med students, or medical students to give treatments to the families and the children that were there, but then also to help with the data entry for that. So speaking of EHRs, these are people who had no concept of pretty much entering in data to keep track of their health. So they were pretty much at the grounds of that whenever I started doing global medical brigades. A couple of these other things are just things that I am proud of. After doing AmeriCorps, after I graduated with my bachelor's, I was able to serve on the panelists for Service Nation, and pretty much that was just a conference for me to go and speak about AmeriCorps and the importance of it, of doing that community service around the country, in hopes that they would continue to fund that project throughout the years. Another one was being an external review for the Cultural Framework for Health, working with OBSSR. And for me, that was just a privilege. Someone coming again from exercise science, not expecting to get into research. These things were just big moments for me because it encouraged me to push further in the field of research. And then just going in order, when I finished my degree in public health, I was interested in doing community organization, really interested in obesity prevention research and looking at just different factors for community organization. And I actually did that project with NIH, and it was just a proud moment for me because just this research idea that you can think is so small that other people gain just large interest in that you didn't think was that big. I was actually selected to be a presenter for at the American Public Health Association conference, I think just last year. And someone kind of entering into the government, I think these things are important because yes, it's good to kind of get your degree as a master, to get your degree in public health or whatever field you're interested in, but I think also having that experience, getting your work out there is important as well. Having kind of some kind of experience before you start your job, I think is important. And the last one, or most recent one, again, as an early career person, I was actually able to lead my first data brief, so it was the adoption of electronic health record systems, and for me that was a big thing, again, because this is actually one of my first jobs after I graduated with my degree. So being able to take lead of that project, them having enough faith in me and the work that I do was just a proud moment for me. Okay, what I wish I knew now at my career stage, as I was discussing, I guess, with someone at work, was the real true importance of networking. Someone coming from South Carolina, I'm really a shy person. I don't like going out speaking to people, telling people about who I am, but I think it was one of the things that I had to learn, again, being a researcher and being in public health. People won't know about your work unless you get out and share it, and pretty much brag about yourself and tell people what you're doing. And I was telling someone before, it was something I had to learn. And other people won't know to talk about it if you don't share it. So really just learning how to brag about yourself and just going out and not being afraid to talk to other people. Just again, with school and life, learning how to control work and school life balance. I like what I do so much that I'll take it home and I'll work on it all day. And so sometimes it can get kind of hard just to learn how to enjoy life. So I think kind of going throughout your career, finishing school or wherever you are, you just have to remember to also have fun and not just be so focused on your work that you don't enjoy the other things outside of your work. Some of the other things, I wish I'd known my real purpose earlier because I felt like I started a little later than some other people in getting into the workforce or understanding what I wanted to do. While I appreciated my journey, again, because I was able to do things like AmeriCorps and Global Medical Brigades, I just wish I'd known about it sooner so that I could be working on more things to move population health forward. I'm going to skip some of the other things, more work-related. As far as my job as a public health analyst with HHS, one of the things that I wish I knew a little more about was the general understanding of policy development. Again, while I started my degree in public health, I was so afraid of taking policy because it was something that I was not that interested in. And when I got into the class, of course, I enjoyed it, but in getting into my job, I didn't really understand the importance of policy and some of the jobs that I had before working as a researcher and seeing how your research can affect policy. And so just kind of having that understanding and taking more than that one policy class that I took for my master's, I wish I would have done a little more for that. And I think that would have better prepared me a little more for my position. All right, and I think that is all I have for talking about myself, and then I'll let our next presenter come forward.
Did you want to talk from there? Or from the
Come there so I can read my slides.
Okay, good.
You know, earlier you heard Karen Lehrman talk about her relationship with program directors, and indeed they are, as people at the Center for Scientific Review, they often refer to program directors as the NIH employees who are shaping the science. And at least that's what they did when I was a review officer. Long before an NIH grant application ever gets considered for funding, it goes through the first level of peer review. And so NIH's scientific review officers see not only the grant applications that get to Glenn Morgan or Susan Chakowski or anyone else who happens to be a program director, they see the cutting edge of science, the things that get discussed, the things that move forward to council, and, to borrow from Hollywood, the things that end up on the cutting room floor. So to tell you about her life story and her career is Andrea Kelly from CSR.
Thank you. Hi, my name is Andrea Kelly, and I'm currently a scientific review officer at this Center for Scientific Review at NIH. And I know that sounds redundant. There are also little review shops within each of the institutes where some applications go, but most of them come to us at the Center for Scientific Review, also known as CSR. You will find in the government we're sort of addicted to these acronyms. Everything has 3 to 5 letter acronyms. I cannot get NIDA to do a study on that addiction, but I'm working on it. So I started out getting a Ph.D. in neuroscience. I was studying neurochemistry. You can see my little rats there. Unfortunately, funding even then was a little bit tight, and that study didn't get funded, so I moved on to hypothalamic and limbic neuroanatomy. So basically, we were looking in rats for different ways that the body regulates its homeostasis. And mostly, we were doing that by looking at gene expression. So eventually, I plowed through that and got a Ph.D. And I came to NIH to do a research associateship, basically a postdoc, at the National Institutes of Mental Health, where I switched fields completely into basal ganglia neuroanatomy. It's extremely different from hypothalamic and limbic neuroanatomy. So that lasted a couple of years, and it wasn't a great fit. So I had recently gotten married, and when we decided to have our first child, I realized that I was going to jettison the plan we had where I was going to be the big earner and my husband would stay home with the kids. And I decided, well, I don't like my job. I want to stay home with the kids. You're going to have to get a job. So poor husband he was an educator and really low pay. He had to go into computers so that I could stay home raising these children. We wound up eventually having 4, 2 years apart. And when you do that and you're not thinking about college, you realize one person staying home, one person working, and 2 of you trying to pay for college, that's not going to work. So eventually you do go back to work. But as a stay-at-home mom, I wound up doing a lot of things as well. One was I joined La Leche League and eventually became a leader and then became an editor of a newsletter there. When my kids were in preschool, I was put in charge of fundraising coordination and eventually became an assistant teacher when one of the teachers was unexpectedly let go over Christmas vacation. And this plays later into a point I'm going to get to where you have a lot more skills than you imagine. I mean, you wouldn't think all this neuroanatomy prepares you for running around after 3-year-olds, but somehow it worked out. Eventually, I did decide to go back to work, and I started out part-time as a contractor to NIH. Mostly, I was covering professional meetings such as this one. I would be the guy up in the corner taking notes, and then I would have a few weeks to prepare those notes, make it look like the speaker spoke in full sentences and everything made sense. Prepare that for an official record of the meetings. And I did that for the National Cancer Institute, the National Institute on Aging. And at one point, I was viewed by somebody in CSR who had someone in my position now, a scientific review officer who'd gotten very ill. He needed a contractor to cover for her. He saw me there at a meeting. I was covering neuroscience. He said, close enough. You can contract and cover for this person, and I did. After a few years as a contractor, I actually applied for and got a full-time job at NIH as a scientific review officer, initially for NIDCD. This is National Institute of Deafness and Other Communication Disorders, basically the Ear, Nose, Throat Institute. And after a couple of years there, I switched over to the Center for Scientific Review. So I did have a lot of on-the-job expertise in terms of parenthood. I should have written parenthood here. It's on-the-job training, 100%. And as soon as you think you know what you're doing, another one comes along and it's completely different from the other ones, so they always have surprises for you. As a contractor, when I was working for NCI, National Cancer Institute, I learned a lot about biospecimen handling, and you think, well, that sounds like a giant yawn. It's actually not. So when you're getting surgery, say for cancer, and someone yanks this biospecimen out of you, how it's handled after that makes a huge difference in whether you can look at it in terms of research. So if this is late on a Friday when you're getting this bit yanked out of you and someone leaves it at room temperature until Monday when the pathologist can come in and evaluate it, it's not going to be very good for looking at, you know, the molecules inside and what they're doing and how things went wrong. So in terms of behavior change, one thing we need to work on is behavior change of the guy yanking that thing out of you to get him to put it somewhere than just on a shelf overnight. But anyway, handling those kind of things, if you handle them all the same way, you can do much better research on them than if they were just willy-nilly until they showed up in your lab 6 months later. So I learned quite a bit about that. I also learned a lot about formal meeting summary preparation, writing and editing, and that kind of thing. Working for NIA, National Institute on Aging, I actually was contracting there after the American Recovery and Reinvestment Act. So I'm one of those people who got a job because of that era funding. NIH got a whole bolus of money for research applications right after that went into effect. And the NIA, one little division of NIA said, you know, we're going to need a little bit of help handling all the applications we have coming in. And I wound up being the contractor to go and help with that. So I had an initiation into Impact2, and this is NIH's enormous database of research applications, reviewers, applicants, that kind of thing. And then as a contractor to CSR, I also learned about finding and assigning the right reviewers for the science that's being evaluated, and preparing summary statements, which are basically taking the critiques the scientists wrote up, making them grammatically correct, like they had full sentences, as if it all made sense. Same kind of thing as I was doing before. So that all sort of came together in my job. So catalytic career moments, one was obviously staying home to raise children. That makes a big difference, especially if you're in a wet lab. If you leave for a few years to go raise your kids, it's a little bit challenging to get back in. People seem to think you forgot everything you ever knew. So that was obviously a career-defining moment. One of the other things that really has helped, and I was kind of surprised about this, was a communication skills class I took as a La Leche leader, so that when you wind up with the situation down here in my comic, so as a scientific review officer, I have to get reviewers to meet all kinds of deadlines, but I have absolutely no way to punish them if they don't. So someone can just come up to me the day of the deadline, or sometimes the day after, and say, oh, I didn't do the work. I found I had a conflict at the last minute, so I'm not going to do it. And my communication skills training helped me not to swear, but to say, I understand your situation. It happens. Let's move on. I'll find someone else to do that. Instead of saying what this little comic lady appears to be saying here. Another catalytic career moment, my husband got laid off. And this was essentially why I started looking for work again after staying home with my kids. We realized we absolutely could not have two stay-at-home parents, so we both started looking. Luckily, he got a job right away, but I had put out resumes and CVs and things, and I found a job listing that said they wanted someone with a Ph.D. in a biomedical science to work part-time, mostly from home. And I thought, did you write that because you knew I was looking? I mean, what? Turns out Montgomery County has hundreds or thousands of overeducated stay-at-home parents. So it wasn't just written for me, but luckily it worked out. So I did get hired for that job. And then after a couple of years part-time, I got hired full-time as a scientific review officer. So the study sections I've covered, which I think are all pretty much related to OBSSR sort of topics. Adult psychopathology and disorders of aging. This is human studies of things like depression, schizophrenia, Alzheimer's, eating disorders, that sort of thing. Communication Disorders Review Committee. This was NIDCD's in-house review committee. So ear, nose, throat, taste, smell, speech, language, hearing, and balance. So that was a lot of topics covered all at once. Language and communication, that's in the Center for Scientific Review. They do a lot of work on autism, stroke, even just human development and how children develop language and communication. And now I'm covering the biobehavioral regulation, learning, and ethology study section. It sounds crazy. Essentially, if you took all the animal studies that feed into the adult psychopathology, the communication disorders, and the language and communication, those come to me. So it might be an animal model of drug abuse or an animal model of autism. We've seen all kinds of funky animal models like bees who have weird social behavioral problems, or larval zebrafish with autism, so it's kind of funky. Things I wish I knew at your career stage. So when I was in graduate school, there were certain advisors, certain researchers who wouldn't take a graduate student who did not say, I want to go on and become a clone of you. I want to have my own lab and be a university person who brings in grants and has postdocs and things like that. Luckily, the people I worked with weren't that uptight about that, because there are a lot of options other than taking that career path. And in fact, there's not enough space in that career path for everybody that's being trained for it. So recognizing that if you don't become a PI and have your own lab, that doesn't mean you're a failure. It just means you're doing something different. I wish I had also known how sparse research funding was. You'd think I would have looked into that before going into that career, but you know, I was young, I didn't know. And as I mentioned, with all the variety of things that I've done since I started school, you have a lot more skills than you think. And you probably can do pretty much anything you put your mind to, or people rope you into because they see that you're overeducated and not that busy. And I guess that's it. Thank you.
Great job. Thank you, Andrea.
Thanks.
Does anyone have questions, or should I start us off? Okay, yes, ma'am. Uma, one of the things you hinted at in your talk, but didn't flesh out as well as I know, are the concentration of services into specific centers, whether they're either nonprofits that contract with the county or your county service centers. Mm-hmm. Would you talk about how that has helped with providing services and perhaps keeping records and facilitating services?
Sure. So our budget's about $300 million at the county level. Over $100 million of that money actually sits in the nonprofit sector. So huge amount of and contract dollars out there, and lots of nonprofits. We have over 650 contracts that the department manages. So some go for $5,000 and some are millions of dollars, right? And contracting in government is probably one of the most painful exercises, whether it's federal, state, or local, it's painful. And so trying to figure out, when I was in Washington State, we used to say you scratch an advocate, you'll find a provider. It's true, right? Our providers have sort of 4 different roles as I see them. They're contractors, they're providers, they are partners, right? And they are fiduciary entities that are delivering service. So they're all of those things. And we use them differently for different things sometimes, and you know this. If you need a certain bill passed or you need a certain service delivery to be stood up quickly, you suddenly go, reach out to your provider community, pull them up. At another time, you're sitting over there auditing books and records and saying, okay, did you invoice this properly and did you get paid? So all of that's true. But I'll tell you, the more, some of our immigrant communities are coming from war-torn nations and they don't trust government for services. They don't. So having the nonprofit be the front face of that service delivery is incredibly valuable, and we recognize that and we use them in that way. And we have, our residents can access us from 50 different access points. 24 of those are private sector, the rest are public sector access points. If you think about it, if we truly want them to come in and be able to access anything, like a true no wrong door, we have to be able to figure out how do we get them to everything that they need so it's not linear. You come in today for food stamps, and then somewhere along the way, 6 months later, you say, you know, you come in sporting a bruise, and the worker says, well, what's going on? And you say, well, I have domestic violence going on, or I'm at risk of losing my housing. But that was probably true 6 months ago. And how do we make sure that we're asking those questions up front and giving you everything that you need so that it's not the 15% that are using 85% of the services? So that's sort of another big pitch. Got to keep moving up the prevention continuum, right? Not deep end, but upstream. The last thing I would say with our providers is, as we're doing the journey for the EHR and the integrated case management system, we also want to collect the right information. Black doesn't mean anything when your population could be from Africa, and Africa alone doesn't mean anything. How many countries are there in Africa or from the Caribbean or you are in fact Native African American from the United States, or similarly from Asia. East Asians very different from South Asians, very different from the Middle East. Asking questions, all of us asking questions of country of origin, language spoken at home, becomes extremely important. And so collectively for us to gather the same data, hold ourselves to the same metrics. Actually, that was not my last point. My last point is that as the immigrant communities are diversifying, a lot of small emerging nonprofits in our community, they have very, very poor infrastructure capacity to meet the audit standards, if you will, for government contracting. But they want to do the work. They're the ones that the community trusts. And so figuring out how we're going to invest in and encourage these small emerging nonprofits to be viable resources in our community while at the same time fulfilling all of the obligations for public sector contracting is a big deal right now in our world. So,
sorry to keep you on the hot seat, but what you just said stimulated a question and borrows a bit from Andrea. There are a lot of overeducated minds in Montgomery.
we have the highest Ph.D. ratio in the whole country. So that's true.
Yes.
It's true. We're very proud of that fact, right? But not always of the cooks and the bottle washers in the ethnic restaurants. So.
Do you think that there are natural partnerships for research opportunities that social and behavioral health researchers can bring to help answer some of these needs in Montgomery County and elsewhere?
Absolutely. So there are some challenges. One of them is data gathering, just basic. The systems are, when I came in, for example, we have about 120 programs in the department that we offer across the Health and Human Services continuum. And I think I had 136 different databases, state systems, federal system, local systems. And so if you had to figure out what services is OMA getting, think about how many different databases and systems you have to ping. And so it becomes very challenging. Depending on what the research topic is, we don't have our own IRB, which means we rely on the state to give us the IRB approvals and the permissions, unless it's a federal or academic researcher who's bringing that with them. And then you've got to think about local capacity. Local capacity is, much of it is really focused on service delivery, much less for research. What we're more interested in is experiential research rather than sort of esoteric ideas that you want to go after. Everybody wants to do evidence-based interventions, evidence-based practice right now. Evidence-based practice tends to be manualized, more expensive, right? How do you get to that gold standard for us in local government? And that's a bit of a challenge. So unless someone's coming with the money, and Montgomery County is not particularly well liked by philanthropy to fund because we're perceived as being wealthy and we are perceived as being much further along. So they would rather go to a community that is poorer and has fewer resources or fewer capacity, which on one level makes sense, but I'm always saying, but we have the ability to deliver, right? We can execute for you in terms of what you need. And so that's a pitch that has to continue. I mean, we would welcome researchers, but we're not a Baltimore City. We're not a Prince George's County. We're not a District of Columbia. And we're surrounded by all of these communities so attracting researchers is a bit of a struggle for us. Okay. But I think we're primed for it.
Okay.
So if anyone's interested, come have a conversation. But experiential research more than
Understandable.
mice and rats, I suppose. Yes.
Right, thank you. Andrea, although this is your first job with NIH, you've experienced all bits and pieces, many bits and pieces of it, not quite all. Have there been any surprises or one core theme that informs all the different places you've been, either or both?
I think one of the things that helped me be all those places was being willing to sort of look outside of my little box. So even though I had done animal work, when I was asked to do the adult psychopathology study section, which was human work, I said, sure, I can do that, which I absolutely did not have the confidence that I could, but it was a lot of on-the-job training and learning, and I sort of managed to figure it out. And I think that's something probably overeducated people can do. You know, you can pretty much figure it out once you get there if you don't have the formal training before you do.
Okay, thank you. JaWanna, you're smiling. I think I maybe not even have to ask questions. Did you have a response to what Andrea was saying?
Well, I was just thinking about my experience. I'm trying to think of can you ask the question again? Because I was smiling. Because I was agreeing slightly.
You have worked in multiple places at NIH. You have worked in a lab/shop at Hopkins. You now work in the Office of the National Coordinator. You're involved in community-based projects in D.C. Do you see commonalities or differences?
There is, and now I remember why I was smiling. The commonality, I think, is similar to what she said, kind of just being open to opportunities. Even when I came to speak, and it was like, well, what's one of the things that I would want to share with people, and it's being open to opportunities, even if they don't sound like something that you're used to doing or something that you might not even be interested in. Just going out there and putting yourself out there, and if the opportunity presents itself, taking advantage of that. And I think, you know, the commonalities in my life that I was also thinking about as you were talking, again, as an early career professional, is also the importance of mentorship, having mentors throughout that entire process. So starting, again, moving from South Carolina, moving to DC, that was a big change for me. And so thinking and kind of moving forward in my career, meeting people like you, as Dr. Powell Wiley, and just other people, even in my current job, because I started off as an intern and I had to have a mentor for that process. And I think just, again, being open to opportunities, but also having a mentor to kind of guide you through those scarier times where you might not want to take advantage of those opportunities that seem very scary. So.
Okay, thank you. Questions next? Yes, sir.
I would say my training helped quite a bit with the work that I'm doing because I probably should have described it. NIH gets about 80,000 applications a year. They get divvied up among about 500 different scientific review officers based on what topics they are. And then we're in charge of making sure we find the right expertise to review those applications fairly and quickly. So being able to read the studies, figure out what they're trying to do, figure out the methods that they're using, just sort of being able to do that critical thinking and sort of rapid analysis, I think helped a lot. So not necessarily, you know, mounting the brain sections on 5 billion slides necessarily helped, but the overall training, I would say, did help. It probably would be wise, even starting in high school, if people knew more about the sorts of careers that are available. I mean, when I was in high school, you could be like, you know, cowboy, ballerina, doctor, lawyer. If someone said, I love geology, I would think, well, what on earth are you going to do with that? Right? Because when you're 17, you don't know. There's a lot to do with that. But you might not make the decision to study that if you don't know that there's any jobs there. So graduate training, probably people should at least be aware that they might not wind up as a PI with your own lab and that there are other options. But even earlier, people, I think, need to know the options more.
And you're next to argue, but I'd like to tag on to that because you said even more in your presentation. There are trainers, academics in multiple programs across this country who, and you studied in one, who say, you know, you must, I will create you in my image and you must go forth and be exactly like me. I think the word that you used is cloned. And there are not enough there are not enough slots for people exactly like them. There are not enough professorships. And there are also lots of other needs, lots of other slots for which people are not exactly being trained. And as we continue to live longer, stay more active, and stave off any kind of dementia, because we constantly learn new abbreviations on the job, we may not want to stay in the same career paths. And so back to you, Bob, perhaps our training could be broadened to ensure that people, as you also said, JaWanna, and your career story, Uma, said, to leave yourself open to the variety of possibilities that can come your way, because you never know when they will pop up and where they will take you.
The one thing I would say, I did my master's in social work right after undergrad, and then took a break, worked for some time before I went back to get my second master's. And I would say I got a lot more out of my second master's than I did out of my first, just because I had the work experience. I knew what I should be looking for and what I wanted out of the program. The one thing I see a lot out of folks coming out now, graduate programs in particular fields, they narrow your scope somewhat, even in terms of you're the only one who can do this right. And so this ability to collaborate gets lost as you come out of graduate school. And we're doing a pretty interesting experiment right now at the universities at Shady Grove, where all the different disciplines, we put them through a 6-week program in the summer with the department. They're all still in school, but we really focus them on integrated case practice. Pharmacists, social workers, corrections officers, therapists coming out of psychology school, nurses. And it's been a phenomenal experience to see them develop and see the value of collaborating across disciplines. And so my hope is when they graduate out, they're going to enter into either local government or nonprofit sectors, not so much research. That's not our focus. Our focus is all around service delivery in the community where folks in need are living, right? That's what local government's focus is all about. We would see them coming out with much different skill sets, and that's, I think, useful.
Thank you. Dr. Diana.
So, good segue. Bill, you actually took my question away, but I forgive you.
Thank you.
I give a lot of talks to student groups, both undergraduate and graduate, and they come to me regularly after, and I'm talking about public sector work, I'm talking about opportunities outside of academia, and they come to me afterward, and they whisper, they actually whisper to me, I've been told not to do that. Their advisors are telling them, that's not the path they should choose. So similar to what you're saying about what Andrea said and what you were saying. So I guess where I'm going with this is a lot of the training we're talking about is how to get people to be more confident, more motivated, to position themselves. I think JaWanna said, I had to learn that it was okay, that I really did know some stuff and I had to do this. But I think there's another level, culture change, that really needs to happen. And I don't know how we make those inroads, how we go into the university settings and we say, it's okay for your students to pursue work outside. As an example, do any of you go into those settings and talk about job opportunities that are available and to the student? Are you ever invited? Are you ever allowed to go in and do those sorts of things? I think we need to have more of a presence in the settings where the students are being told not to do the things that we need more qualified people to be doing.
Okay. Thank you.
Yeah, we could call a fair amount of time to the universities at this, both at the University of Maryland, mostly at the University of Maryland, College Park, and/or the universities at Shady Grove, sometimes at Catholic or Howard, to come and talk to schools of social work. Primarily, that's the discipline that tends to reach out the most.
But there are a lot more universities that we need to start visiting. But sadly, there's no more time for our panel. Okay. So if you thank our distinguished guests, we'll make a transition. Ladies, I'll follow you off stage. Thank you all so very much.